Test 1, 2, test 1, 2.
Good evening, everyone. My name is David Elwood. I'm the Dean of the Kennedy School, and this is a wonderful occasion. It's a wonderful occasion because we are here to celebrate the inaugural lecture of the Jonah Angelopoulos Daskalé and Theodore Angelopoulos lecture. And this is a very important lecture series because it's part of a very important initiative that the Angelopoulos were kind enough to and have the vision to do. This lecture is a lecture to promote more effective governance, improved health policy, and effective global leadership through inquiry into and discussion of key issues related to those goals. What's also unusual about this one, I believe it is unique perhaps around the Kennedy School, this is a lecture that's decided upon and sponsored jointly by the School of Public Health and the Kennedy School of Government. The kinds of issues that involving global health, involving governance, involving poverty, involving the economy, as well as involving all kinds of issues surrounding public health are clearly issues that span boundaries. And the Angelopoulos actually believe that we can span the Charles River in moving forward. And this lecture series is part of it, as is a new chair that was just announced tonight. I should just say one or two words about Jonah and Theodore. They've done much to help Harvard and significantly enhance its work. They've been leaders in both the public and private sectors. They've made significant contributions to Greece, their home country. Theodore has spent his last 30 years leading and expanding an internationally based private group with interests in shipping and steel, private equities, and other financial opportunities. And he is absolutely devoted to promoting public health care, and he's served on the Harvard School of Public Health's Board for Cancer Prevention and on their visiting committee. Unfortunately, Theodore cannot join us today, but quite honestly, if we had to pick one, we got the better one. Of course, I haven't met Theodore, so I can't. But Jonah Angelopoulos Daskalé is a remarkable woman indeed. So remarkable indeed that she's going to speak on this very podium tomorrow night. So I urge you all to come back and hear more about her experiences, where she as president of the Athens 2004 Olympic Committee, organized the Games in one of the smallest countries ever to have the Games, and did it with remarkable grace and style, in spite of the fact that everyone said it couldn't be done. Through her work, Jonah united the nation behind the effort to bring the Games to Greece, back to Greece, gave the world what the International Olympic Committee called an unforgettable dream Games. She served on the Athens Municipal Council and the Greek Parliament, and was named by Forbes and Fortune magazines as one of the world's top 50 women managers. So she's truly a great leader. So we're going to hear from her tomorrow night, but briefly tonight, in the inauguration of this lecture, let me ask you to welcome Ambassador Angelopoulos Daskalé.
Good evening. Thank you very much for joining us at the opening of the Angelopoulos Lecture Series. My husband Theodore very much regrets that he is unable to be here tonight for what is a very important evening for us both. He has put a great deal of thought and effort into this series and to the chair, and I know that he shares my hope and my belief that this is the beginning of an important era at Harvard for a unique and vitally important program. I want to express my real gratitude to Harvard University. This wonderful, how can I describe this famous institution, especially to President Summers, to Dean Elwood, to Dean Bloom, and I wanted to thank them especially for the work they have put in that. Theodore and I have long hoped to find a way to translate our vision of a more effective and humane global health regime into action. I'm convinced that the lecture series and the Angelopoulos Chair will do that. Of course, we were delighted with the selection of Dr. Christopher Murray as speaker for the inaugural lecture. He is an extraordinary thinker, yet one whose ideas translate directly into public health policy that saves and improves lives. Christopher. In addition, our goals in endowing both this lecture series and the Angelopoulos Chair fit closely with the goals of the initiative Dr. Murray heads, to create a new generation of thinkers and leaders in the global health field. My family is deeply involved in international business. We believe that the private sector is well positioned to do many things that government cannot or should not do. But I also live, like everyone else, in a world put at risk by challenges that cross borders and threaten human beings' lives. So many of those most difficult challenges involve public health. And when I hear of a public health challenge, I ask myself, where is the government? How could an effective nation or coalition of nations have better handled or prevented the problem? In an age of global and regional military alliance and growing trade and economic arrangements, why are international responses to health crises often so late, so short-term, so ad hoc? And why is there such a gap between the modern tools and practices available to healthcare professionals and those obsolete strategies and actions governments turn to? Why do we let that gap persist in ways that so often cost lives? I believe this lecture series is an important step towards closing this gap. Today, public health threats cross national borders with the speed of a jet. We can see more clearly that ever the links between public health and economic, political, and governmental factors. It is therefore vital that we find the development and governing strategies that will improve public health through use of 21st century ideas and technologies. Public health is not only as important as economic and national security. Is not only, I repeat that, it is an integral part of both. With these lectures and with this chair, we have begun to recognize those relationships and have given Harvard, once again, the opportunity to lead scholars here and around the world as a trailblazer of important research and as an actor to improve our lives. Thank you once again for attending. Thank you.
Thank you, Jonah. It's, again, very inspirational, and we look forward to hearing more about your work in the Olympics tomorrow night. I want to now introduce Dr. Barry Bloom, who is the Dean of the School of Public Health. It's easy to look up his remarkable achievements. He's, for example, remains as a principal investigator and a bench scientist researching immune response to tuberculosis, a disease that still claims more than 2 million lives a year. He's been extensively involved in the World Health Organization and Global Advisory Committee. He's a member of the National Academy of Sciences, the Institute of Medicine, American Academy, and the like. But I know Barry as an extraordinary dean, a dean of the School of Public Health since 1999. What makes him extraordinary is, besides his being a remarkable scientist, he also believes deeply in the power of knowledge, of work, of activity to make the world a better place. And no place is more important than health and the health of citizens in terms of advancing that agenda. At every meeting I go to with Barry, at everything he does, that passion, that desire for excellence, but also impact is always present. So let me introduce to you Dr. Barry Bloom, Dean of the Harvard School of Public Health.
David, thank you for those very kind words. And Jana, it is such a privilege to hear your understanding of what we're about in preventing disease and keeping people healthy, and to be inspired by your having pulled off the Olympics in a way that prevented all the dreadful things that could have happened, which is for us in public health a real milestone. I feel privileged as well to be able, through this gift, to be able to hang out with the Dean of the John F. Kennedy School of Government. If you look at David's passion for doing something about poverty, and the passion of my colleagues who are worried about the health of the poor and disadvantaged, the potential synergies that have been brought about by this marvelous gift really leave unlimited horizons for doing creative things at this university and around the world. I'm also now privileged to introduce my friend and colleague, Chris Murray. And Jana again described him as an extraordinary individual. He was born in New Zealand. He graduated Harvard in 1983 as a summa cum laude. He was a Rhodes Scholar to Oxford, where he wrote a thesis relating what diseases correlate with economic development. And he is one of a new generation of economists who believe that the standard mythology that if you get a country's macroeconomics right, health will follow, is not correct. And it is equally true that if you get the health of a population, even if they're not very rich, you can have great impact on the quality of life. At one point in his life, when I used to call him at 3 o'clock in the morning, he was an assistant professor at the Harvard School of Public Health. He was a major consultant to the World Bank in 1993 in its World Health Reports. He was a medical student at Harvard Medical School and ran the operational committee, research committee at the World Health Organization, all at the same time, and he could only be reached by telephone at 3 o'clock in the morning on the wards. So he is indeed a special person, and I think exemplifies the vision of the Angelopoulos chair and lecture series, because one of his missions is to ask the question, how can we hold governments accountable for the health of their people? And I think you will hear tonight what his vision is of how to do that and address some of the major problems. Chris?
Good evening, and thank you all for those very kind words of introduction. I certainly don't deserve them, but I will try at least to cover, I hope, a wide range of either controversial or interesting material. What I'd like to do is give you two blocks in this presentation. First, a sort of quick run through what I think of as the major problems in global health, as well as at the disease level, as well as at the system level, and then give you a very personal view of 8 opportunities that we have globally that I don't think we're taking full advantage of, and then end with one last comment which really goes back to Jana's comments at the beginning, which is what is the appropriate role of the state in tackling these issues. So first, the quick view of patterns of disease in the world. So let me start with my own favorite way of thinking about that, and this is results from the ongoing global burden of disease work that WHO now undertakes, that we started some 12 or 13 years ago, which is an attempt to add up all the years of healthy life that are lost in the world and attribute them first to diseases, and then in a moment I'll talk about risk factors. So these are the top 10 causes of ill health and mortality. Conditions arising during the perinatal periods, number 1. Pneumonia, a killer of poor children in poor countries, number 2. HIV/AIDS, now number 3. And then remarkably, depression is right there after HIV/AIDS as the number 4 cause of ill health in the world. Diarrhea, back to a killer of poor children in poor countries. We have then 2 chronic diseases, ischemic heart disease and stroke, malaria, road traffic accidents, and TB. This list of 10 is both important because each in their own right is a high priority for us as a globe, but it also illustrates the extraordinary complexity today of what are the priorities. They're not just communicable diseases, they're not just chronic disease or heart disease, but includes things like road traffic accidents as well. Now, diseases are one way, and it's certainly, if I put on my doctor's hat or my physician's hat, that's the way we tend to think about the world. But if you think about other causes of the problems in the world that aren't diseases, but the risks or social exposures that lead to disease, we get another way of counting up the problems in the world. The writing is small, so I'm going to tell you what the basic message on this slide is. These are the major risk factors in the world, going from malnutrition on the top and unsafe sex next, right down to the one that's lowest on this list, which is childhood sexual abuse. But you can boil down this pattern of risk into two broad groups. One group of risks that are predominantly in poor countries, that are predominantly killing children, or in the case of unsafe sexual practices, killing adults as well. That's malnutrition, unsafe sex, unsafe water, indoor air pollution, and then a series of micronutrient deficiency, iron, zinc, and vitamin A, that account for a lot of the death of children in developing countries. We then have 7 big risk factors that have those 3 colored stripes on this diagram. There are 3 colors because yellow is the burden of disease in the poor countries, red is the burden of disease in middle-income countries, and green-blue, whatever you wish to call it, is the burden in the high-income world. And you'll notice that there are 7 risk factors up there that have that 3-striped color. High blood pressure, tobacco, alcohol, high cholesterol, obesity, low fruit and vegetable intake, and physical inactivity. And those 7 together are what drive the other part of the disease profile I spoke about a moment ago, namely the rise of heart disease, cancer, and other non-communicable diseases. We'll come back to what we can do both on the disease level and the risk factor level in a moment. Now, one risk factor deserves special attention, not because it's the biggest. You saw on the previous slide that in fact it's about the 11th or 12th sized risk factor. But obesity is alarming because the trend is going up rapidly everywhere we look. That's not the case for all the other risk factors, which are either constant or getting better. So there's something unusual, and this is actually, remarkably, all the available data on time trends of obesity around the world using actual direct measurement. There's other data around where you ask people, are they obese? And we could have a discussion about that. But in terms of actual measurement of obesity, you see the US on the top line going up from about 15% obese 25 years ago to over 30% today. But notice the trend for Australia, England, and unfortunately New Zealand are going on the exact same slope as the United States. This rise of obesity is not a US phenomenon. It's something that's happening everywhere we measure it. It's even happening in over a short period of time in Korea, as you can see on the bottom right, where although they're starting at a very low level of obesity, the trend appears to be the same. And we have hints that this trend in obesity is also taking place in China, it's taking place in the Middle East, and certainly in Latin America. Well, risk factors are one thing, and diseases are another aspect of it. And if we look today, you will notice that none of the listings that I gave you mentioned, for example, bird flu or any other epidemic. The reason is that the analysis of the last 5 years simply tells us about what is the regular or ongoing pattern of disease, both in poor and rich countries. This one slide summarizes 250 years of health experience in the country that we have the longest running data for, Sweden. The left panel is child mortality, the right panel is young and middle-aged adult mortality. And you'll notice that in the last 100 years, the line is sort of smooth and declining for children on the left, and smooth and declining for males and females in the young adults and middle-aged adults on the right, but there's that little big spike in 1918, if you notice on the right-hand panel. That spike was the Spanish flu epidemic in Sweden that took place in 1918, 1919. It's similar to the spikes that you see farther over on the left, which was the era of the great epidemics from 1750 to 1850, but largely went away. And it's a reminder that even though there was only one of these extraordinary epidemic spikes in the 20th century in Sweden, it was a huge one. In fact, we can go back to 1918, 1919, and 1920 and ask the question, how much mortality was there from Spanish flu, And we're lucky because there's a group at Berkeley that have gone back and collected all the available vital registration data of high quality in that period around the world. And we can figure out how much did the Spanish flu epidemic actually kill. Take those death rates and apply them to the world today. That's not saying that's ever going to happen. It's not saying that the bird flu that we're thinking about today will cause this sort of epidemic. But it's saying if we replayed that epidemic from 1918 and 19 today, and we had exactly the same set of outcomes, 54 million people would die, and you can see the regional distribution, most of them, of course, in Asia, largely because of population. But we can say, well, that's got to be slightly higher than we would expect, because there wasn't much in the way of supportive medical care or antibiotics for secondary bacterial infection after pneumonia, after influenza. And so we can look at the other pandemic in the 60s, the 67 to 71 pandemic, and see how the relationship between healthcare spending and mortality at that period attenuated the effect of an influenza pandemic. That sort of factor would reduce the expected burden from a 1918-like epidemic to 38 million, which is an extraordinary number. That would increase global mortality by about 60% in 1 year. So the story is largely about the big infectious killers of children, about the rise of chronic disease in adults, but we need to keep in the back of our mind that there are these risks of new global pandemics. Well, if we want to do something in the policy arena about global health problems, then we need to look at the resources going for global health. In 2002, the last time this sort of assessment has been undertaken, there was about $3.2 trillion spent on health around the world, almost half in the United States. Half the world's health spending here, another quarter in the European Union, another 16% in the rest of the developed world. The developing world, including China, India, Latin America, and everywhere else, spends about $400 billion on health. Of that whole global pie, sub-Saharan Africa accounts for 1%. So there's an extraordinary range of resources going into health across health systems. It may be unjust, but it's a reality about thinking what is achievable in healthcare in different settings. Now, there's been a lot of discussion about rising global commitment to the challenges of the health of the poor. And there's been important work, some of it coming from the Kennedy School with Jeff Sachs and the Commission on Macroeconomics and Health when he was here, and the general push to put health at the center of development. And that has led to a rise of the Western commitments to healthcare in the developing world, so that bilateral commitments, not counting the UN system, have gone from about $2 billion for health in the developing world in '97 to about $4 billion in the year 2003. The red part of those bars is what's going for HIV. So most of the increase is money directed towards HIV, but there's still been a doubling of resources flowing to developing countries. But remember, the developing world spends $400 billion of their own money, and this is $4 billion on top of their $400 billion, about 1% extra, even if it is, we hope, going to preferentially to the most poor. So if we put those two bits of things together, health outcomes and money, we get both the challenge and also the thing that holds out hope that studying health policy will yield insights that will make people's lives better. So on the x-axis here is spending per capita, including aid, domestic resources and aid, and on the y-axis is one overall measure of health, healthy life expectancy, how many years you can expect to live in full health. And you can see there's a huge spread across countries, going on the logarithmic scale of the x-axis from countries that spend only $10 per capita to the US that's spending just under $5,000 per capita in 2002. And you can see that there's also not only a spread of spending, but there's an enormous range of outcome. So at any given level of spending, look at $100 per capita, you have a country like Georgia seemingly to do very well, and countries that have healthy life expectancies that are half the level of Georgia at the same level of spending. If we could just understand why, then we could take lessons learned from those that achieve a lot with the available resources, and we would hope transfer them to countries that don't achieve very much. One of the great beneficiaries of that, of course, would be the US, because you can notice that it's way over there on the right-hand side. It's spending the most, and it's actually doing rather poorly. It's towards the bottom of the pack of the high-income group. So lessons to be learned all around if we could only unlock the secret of why some systems perform better than others in terms of health. All right, well, that's a quick run through essentially the context for global health. And what I'm going to give you now is 8 opportunities. These aren't the only 8 opportunities. You could argue, and I'm sure if Dean Bloom had the opportunity, he would debate me no end as to whether these are the right 8 opportunities. So I will confess now, this is a very personal view of things that I think are out there that we can do that are being neglected. First, a lot of discussion in the world today about malaria. It's one of the big 3, AIDS, TB, and malaria. And there is new resources for malaria from things like the Global Fund for AIDS, TB, and Malaria and the new malaria facility at the World Bank. There's lots of bits to the technical strategy, but there's only 2 that really matter for malaria. Artemisinin combination therapy to deal with drug-resistant types of malaria, and insecticide-treated bed nets, proven in randomized clinical trials in sub-Saharan Africa to reduce child mortality in endemic areas for malaria by 20%, a huge reduction in child mortality, and a 5-year bed net costs only $5. So you would think that this was an extraordinary tool that we could use to attack malaria. Strangely, after a number of years of promotion of insecticide-treated bed nets, in 2003, the World Health Survey, conducted in about 70 countries, gives us comparable information on the coverage of bed nets. In sub-Saharan Africa, the highest coverage is in Malawi. 20% of children are sleeping under bed nets, but most of sub-Saharan Africa, in a malarious region, it's under 5%. So we are not using this extraordinarily effective tool. And I've frequently asked people in the malaria community, when your brethren in TB, pushing dots, the folks over in the HIV program pushing antiretrovirals, are taking quite expensive therapies, making them free, and trying to push out the dissemination of these, and you're still in policy dialogue asking people, poor people, to pay for these nets because you don't think it's sustainable to give them out for free. There's something not right here. Here's a strategy. There's resources available for malaria. Other major disease programs are making their interventions that are much more costly free. We should be doing the same thing for bed nets. It works. It's being underused. Policy opportunity number 2. We're in a period of dramatic turmoil in the child survival community. The child survival movement had tremendous impetus in the 1980s. Jim Grant, who was a charismatic leader of UNICEF, really drove child survival up to the top of the political agenda. When he left UNICEF and actually passed away, that leadership actually dissipated. The world moved on to other topics. And in fact, the child survival community adopted a strategy called IMCI, Integrated Management of Childhood Illness. And for 12 years, this has been the mainstay of the policy world discussion about child survival. It's a facility-based strategy. You train up the local staff to be able to diagnose and treat a sick child when they come. And it was thought to be the right thing to do. It made sense. Fortunately, I think for the world, a systematic independent evaluation of IMCI has been conducted by a number of groups, and they chose the program that was supposed to be working the best, Bangladesh. And the one line in the published paper has devastated this field, which is in Bangladesh, in the treatment villages, getting IMCI, 19% of sick children get treated at an appropriate time, as compared to 9% in the control villages. This is the best program that they could evaluate, not much of an effect. So suddenly the field is saying, well, what's our strategy to reach sick children, especially when we have a whole bunch of new technologies to do something good for children proven in clinical trials. And so we have a great policy opportunity now with new leadership at UNICEF, where UNICEF is coming back to the table to focus on child survival. Just to assure you that there are a lot of opportunities if we could only figure out how to deliver them, here's the top 10 interventions that are being underused and the fraction of child deaths that we believe could be reduced by delivering new strategies like zinc or Haemophilus influenza B vaccine, along with some of the more traditional strategies that are still currently used. So, policy opportunity number 2, figure out, design and test new service delivery strategies that get us out of the clinic and delivering highly effective technologies to poor children in remote rural communities. Policy opportunity number 3, reduce deaths from road traffic accidents through a package of highly effective, proven policies with very strong evidence behind them. Most people in high-income countries, particularly Western Europe, Australia, and the United States, lived through the pretty dramatic decline in road traffic accident mortality that started with the recognition of the problem in the late 60s and the testing and implementation of a whole series of policies, from seat belts, airbags, traffic calming, speed limits, alcohol breath testing. Remarkably, although some parts of that package, not the road design part, but everything else, is quite cheap, there has not been as much spread of those policies outside of a certain set of high-income countries. And in honor of of this lecture and the Angelopoulos family, I've also got Greek data to show you here as well. So this is the actual decline, first in the US and Australia. Notice that US road traffic mortality started dropping in the 70s and dropped quite precipitously down to 1990 in red. We haven't made much progress in the last 10 years. In contrast, Australia, who introduced the same type of policy package, but then introduced highly aggressive alcohol breath testing all over Australia, has had a much more marked decline in road traffic accident mortality. Greece, up until about 5 years ago, was going in the wrong direction. Road traffic mortality was going up as Greek society became more motorized, and it's only since about 1997 or 98 that there has been the beginnings of a steady decline in road traffic accident mortality. The sad news is, if we look at Eastern Europe, the former Soviet Union, and the rest of the developing world, that decline has not started. And this is really something that is affordable, certainly for the middle-income world, and arguably even for low-income countries. Policy opportunity number 4, community treatment of major psychosis and depression. 10 years ago, if you had stood up in any audience about global health and said that mental health was an issue for low-income or middle-income countries, nobody would have taken you very seriously. However, as there have been many national studies about the burden of disease, and there's been wider appreciation about the magnitude of mental health disorders as a source of disability, not mortality, there has been increasing policy discussion about what can be done about mental health. So we've gone from a stage of lack of recognition of a problem to recognition of a problem, but we still have a state where most people think you can't do anything feasible in the low-income or middle-income world. But in fact, we can do quite a lot. Although we can't address the entire burden of neuropsychiatric disorders, we can actually get enough of the burden of disease attributable to mental health addressed with current pharmacological therapies, such that if we actually implemented these programs in the community in developing countries, we would reduce the burden of disease globally by 2%. To remind you, that's the same fraction of burden that tuberculosis accounts for in the entire world. So although pharmacotherapy for depression and psychosis can only get at about 20% of the problem, that 20% of a huge problem is well worth the policy introduction. And it's been sad to watch as the global community started to gear up to think about mental health policy around about 2001, 2002, with the leadership of Gro Harlem Brundtland at the World Health Organization. But in the last 2 or 3 years, with the increasing focus on HIV, TB, and malaria, that is starting to go away. So there's much less discussion or focus on the opportunities that we have to do something about this huge neglected source of the burden of disease. Number 5, the last of my disease-specific policy opportunities before going on to health system opportunities. That is the one that I believe is a tremendous opportunity that is simply falling through the cracks. That is to use the famous polypill, which I'll talk about in a moment, to reduce heart disease mortality in the developing world by half. Well, we know there's a huge burden of heart disease. We can argue what the trend is, but by anybody's account, in places like South Asia and Latin America, there's a huge burden. The strategy that has been so successful in the West of reducing heart disease mortality is not going to work in the developing world, even the middle-income world, because it's just too costly for that setting. And on the flip side, there's nobody in India or Latin America really taking seriously the need to come up with local solutions to address the burden of cardiovascular disease. Those institutions are still focused on tackling maternal and child health. And unfortunately, either the international organizations that might do something to come up with solutions, NIH in the US, aren't interested in chronic disease in developing countries, nor is the Gates Foundation, and nor is the pharmaceutical industry interested in developing low-cost interventions for the poor in developing countries. So what's actually the magnitude of the problem? The big circle there is the burden of cardiovascular disease overall. 3/4 of that burden of disease, or 70%, is in the developing world. So counter to the usual idea that heart disease is a disease of affluence, it actually turns out to be a disease of the poor. There's 11 million deaths or over that in the developing and developed world from heart disease, and the current trajectory is that will increase by 60% in this next generation. Well, there's lots we could talk about tackling it, including particularly tobacco control as a major strategy for the developing world. But there's also a proven series of components for those big risks that I showed at the beginning of the talk: blood pressure and cholesterol. Blood pressure being the number 3 risk factor in the world, cholesterol being about the number 6 risk factor. And there's the idea, has been around now for about 5 years, that we can take off-patent drugs for cholesterol, for blood pressure, put them together, deliver them to individuals 1 pill a day. That's the actual pill shown there, now produced by Dr. Reddy's pharmaceutical company in Hyderabad. And that pill, if the component trials actually worked when we delivered this in the population, would reduce heart disease risk by 65%. So this would have an enormous effect. Because it's a single pill, needs a very simple diagnostic strategy. It could be implemented even in the settings without physicians. It's a very exciting idea. It's been around for 4 or 5 years, and unfortunately, it's languishing for lack of a champion to take forward the polypill idea, both to prove its efficacy in a developing country, as well as to figure out how to deliver it. The science behind it is individual trials that show treating blood pressure can reduce your cardiovascular risk by about 30%. Blood pressure and cholesterol, you get another 30% reduction, and adding on aspirin gives you another 1/4. So all in all, you can bring down cardiovascular risk by about 65%. Well, some people say, when this idea was first floated, that we would be impossible to get people to take a pill a day, that individuals aren't willing to medicate themselves, especially when they don't have disease yet. They may not even know they have elevated blood pressure and cholesterol. So is there any hope to convince people to take a polypill every day? And I think there is. This is a slide of multivitamin use in the US by age, the pink and the blue bars for males and females and males, and compared to statin use amongst those who need a statin with high cholesterol. People are much more willing to take a polypill. It's just the wrong polypill. They're taking multivitamins, which actually don't probably do very much as far as we can tell. So it's not that people won't take pills. It's that they are worried about taking drugs as opposed to something else. And I think part of the challenge, both for blood pressure and cholesterol and for other things coming online, is to demedicalize pharmacological risk management. All right, that was a series of health or disease problem-specific opportunities. I would like to give you now 3 opportunities that are more on the health system side. We have increasingly learned in the last, I'd say, 5 or 6 years that not only do poor households, and in some cases middle-class households in developing countries, get sick at very high rates, both from communicable and chronic disease, but because they seek health care for their family, they often push themselves below the poverty line. They face catastrophic health spending. This catastrophic health spending, spending a huge fraction of your disposable income, isn't restricted to the poorest countries. It's actually occurring all over the place, including in the United States, as there's a whole series of studies on the percent of households here that face catastrophic health spending. It's occurring everywhere, but it occurs in some settings much more than others. It particularly occurs with the constellation of high levels of poverty, a lot of health services in a society, and the absence of insurance or tax-based funding to protect people from financial risk. Here's the data as we know it. This is 100 countries where we actually have household survey data on the fraction of households that face catastrophic spending. So this is a well-characterized problem. And it ranges from the bottom left. These are both log scales for the audience. On the bottom left, less than 0.01% of households in actually Bulgaria facing catastrophic spending, up to the top right where Brazil and Vietnam are having catastrophic spending rates of 10% or more of households each year spending more than 40% of their disposable income on healthcare. And there's this huge spread in between. You'll notice there's a very strong relationship shown on this diagram with the fraction of out-of-pocket spending. And what this simply reiterates is that when people are paying for healthcare out of their own pocket, they don't have insurance, or the government's not have employer-based insurance or tax-financed health care, you see very high rates of catastrophic spending. Can we do anything about this? Is this something that you have to wait until you're a high-income country to put in place social insurance or safety nets or tax-based financing, such as the UK? And I think the experience in Mexico tells us no. There are concrete policy initiatives in the developing world that hold out the prospect to tackle catastrophic health spending as a problem and also do achieve other things at the same time. So Julio Frank, who I had the honor and pleasure of working with at the World Health Organization, moved from WHO to become Minister of Health in Mexico when Vicente Fox became president. And over the course of 3 years was able to create enough social consensus about doing something about catastrophic spending that they enacted in May of 2003 the Seguro Popular bill, which extends insurance coverage to the 50% of the population that did not have insurance. And that's happening starting January of 2004 over a 7-year period. And this covers a pretty extensive basic package of services, including 91 major disease and intervention categories. There's a certain irony that south of the border in Mexico, society has come together and decided to enact universal health insurance, or at least achieve universal health insurance over 7 years, when in the United States, of course, that social consensus has not come about yet. So there is hope on catastrophic health spending. It's a huge problem, but one for which there's a real opportunity to make further progress. Dean Bloom alluded to the issue of creating accountability for health systems. And this is, to me, the 7th opportunity that I want to emphasize, one that I'm personally very a great believer in and very personally committed to. That is, it's very easy to have poor-performing healthcare systems when we don't know what they're actually doing. When you don't know how much money or how many people are going into healthcare and public health, and we don't know what they're actually delivering to people in need, and we don't know what sort of impact that has on population health, how is it that anybody's going to be held to account? How is it that anybody's going to learn from success where it's occurring? And how is it that we can make any concrete progress if we don't know where we're coming from? We began at the beginning with the huge variation in health outcome compared to spending. Behind that variation is also a component that's due to public health and medicine. Not all of it, because we know the economy, education, the environment also influence health. But at least within public health and medicine, we should be understanding what the systems are doing, and are we making progress, and are we delivering care in the most efficient way. So the core idea here is that credible, comprehensible, not comprehensive, but comprehensible by the public, and comparable information on health systems is an essential ingredient for creating accountability. One of the key components to that monitoring of health systems is what we call coverage or effective coverage, and that's the intervening mechanism by which public health and medicine delivers technologies to people in need and makes a difference to their health. If we had better information on that and could relate that to resources, we would be in a strong position to identify who's a good performer and who's using resources efficiently. So here's our first pass at this using the World Health Survey, 70 countries, in 2003, implemented in exactly the same way in all countries. On the x-axis is spending on a log scale, going from $10 or just over to the $5,000 that we know about in the US. And on the y-axis is the composite measure of 8 maternal child health, cancer screening, and general health service interventions. And it shows you the same relationship that we sort of saw for health outcomes and expenditure. Countries that spend more get more. So as we put more money into healthcare systems, we can expect them to actually deliver more goods to the people. But at any level of resources, in this metric of service delivery to those in need, there's enormous variation. Look at the pair of Chad and Malawi, both spending the same level. Chad is delivering about 15% coverage of those 8 interventions. Malawi, double that coverage. Why? That's the sort of question we need to understand, because if we can figure out what's going right in Malawi, we may have some lessons that are going to be useful for Chad. Look at the unusual pair of Ukraine and Swaziland. Swaziland's actually spending more than the Ukraine, which I find remarkable, but apparently true. But it's achieving, again, about half what the Ukraine is in terms of service delivery. So there's both the message that more money is important, particularly at the low end, but we have the potential by monitoring and reporting to each other on health system performance of learning how to do things better. My 8th and last of these policy opportunities. One of the most disturbing things, I think, for health policy has been the persistence of large inequalities in health in high-income countries, even the United Kingdom with the National Health Service. And so the fact that there's still a huge gradient by social class, by income group, by education, in a country with guaranteed at least financial access and probably physical access to health care and aggressive public health interventions is deeply disturbing. And in fact, it's triggered a whole series of reflections, particularly strong in Canada and Britain, that maybe the way to address these persistent inequalities in health, the lag or the people left behind, is not to deal with healthcare, but to try to tackle poverty and the broader determinants of health. That, of course, is a long road to walk. And in fact, it's one that I think I applaud, but I'm trying to think of a more narrow approach to supplement those ideals of reducing poverty and income inequality that's more specific to public health and medicine. Can we do better in public health and medicine to reduce these persistent inequalities? Well, just to remind this audience that persistent inequalities is not just a phenomenon in Britain or Canada, but in fact is probably the largest in the United States. And here's just one of what could be myriad illustrations of this phenomenon. That is, this is life expectancy at the county level for the 8 worst counties in the United States on the bottom and the 8 best counties in the United States at the top. You'll notice that the 8 worst counties are not getting better over the last 20 years. The 8 best, and actually the country average, is getting progressively better. How can we do something about persistent inequalities? Well, one strategy is to take proven technologies. Risk management is one example. It's not the only one. Tobacco control is another. Alcohol control is another. But what happens with all new health knowledge that we see time and time again is that they get used by the rich more than the poor. So we progress in terms of health, which is great, but we actually don't do as good a job at delivering these interventions or convincing individuals to use these interventions particularly at the disadvantaged end of the spectrum. Fact number 2, economics has taught us many things, but one very powerful thing, which is that financial incentives and other types of incentives can change behavior. Let's bring those two ideas together and think about ways to use incentives to get, for example, disadvantaged people to use statins and antihypertensives. Turns out in the US, you would do a huge step to narrow inequalities if we actually appropriately managed just 2 risks, or 3, tobacco, blood pressure, and alcohol, and cholesterol in the poor. So let me end with one slide trying to bring together one issue that's hidden behind all those opportunities, or many of them that I described. The history of public health has mostly focused on child health for a reason, that it's very easy to create a social consensus that we as a society and government as our agents must do something about protecting children because they can't necessarily protect themselves. But increasingly, the health problems that we see, whether it's heart disease, whether it's HIV in adults, whether it's even TB in adults, or whether it's road traffic accidents, affect young and middle-aged adults, and in fact, largely affect young and middle-aged adult men. And it's not a very popular thing in most societies to go about arguing for social action or government interventions or resources from taxes being used to target adults, or particularly adult men. And we have a choice on those policy opportunities, and we have a choice in every society, and I think you see this playing out increasingly in public health and medical care. Are we going to simply provide information to the consumer about what's good for them and let them make their choices? That works for high-income and educated groups quite well. We've seen this, but doesn't seem to work for large segments of the population. And if we want to do something and take advantage of these opportunities, we have to make this choice as to whether we want to sanction or accept a more interventionist role in public health for government. So I will leave you with that thought and leave you with my 8 ideas that we might capitalize on for the future. Thank you very much.
Thank you, Chris. Certainly a terrific inaugural lecture and much to chew on, literally and figuratively. So there's a little bit of time for questions here. We have microphones at 4 places. There's one here, one there, and one down here. And just a couple of ground rules. A good question has several important features in common. One, it starts by identifying yourself. Second, it involves one short statement that ends with a question mark. And so right here.
Steve Helfer, I am a library assistant at the law school. I'd like you to address the circumstances of Japan, which has, according to the World Health Organization, the highest life expectancy, healthy life expectancy, yet has a high usage of tobacco and very low expenditure in terms of health intervention.
I think Japan is a good illustration of the fact that there are determinants outside of public health and medicine that are partly to account for their very high level of life expectancy and probably high level of healthy life expectancy. Otherwise, it's very difficult to see how to explain that. The one interesting thing, though, is that if you look at the trend for male life expectancy in Japan, that it's starting to flatten off, and in fact, the Australians are gleefully predicting that they will outstrip Japanese males within a year or 2 in terms of life expectancy, because they're on a trajectory which keeps going up, and Japan males are starting to flatten out. And that's thought to be due to the high levels of tobacco finally catching up with the Japanese male population.
Right over here.
Professor, my name is Jonathan Junitas. I'm a scientist at MIT. I should like to ask you why it is that Georgians are so healthy for so cheap.
I do not know. I think that's the type of... we can only ask that question once we finally get this type of information together. So that's the sort of next evolution of being able to benchmark what systems do, which is ask these strange questions. Back in 1980, when we made that type of graph, Cuba, China, Kerala State in India, because the country of India was broken down, and Costa Rica stood off the graph for life expectancy versus income or health spending. And that spawned a whole series of analyses trying to reflect on why that set of 4, and Sri Lanka could be added to that, had better health. What's interesting is that relationship's dynamic. Sri Lanka and China are no longer up on the top of that graph. Things haven't gone as well in the last 20 years in terms of health. And so having a unusually good performance in health isn't a permanent attribute. It's not something that once you achieve, you're going to stay there and stick to that trajectory. And I think it's the type of question you're asking, which we hope you, others, many will sort of try to explore.
Thank you.
Right over here.
Professor Murray, my name is Ozren Tosic, Master in Public Health in '96, and your student at that time. I would like to point out. I would like to point out that in terms of efficiency and performance in developing country, corruption in the health sector takes a huge part. For example, in Serbia, where I come from, according to different estimates, 40 to 50% goes under the table of total health expenditure. And that also influences another issue that you have mentioned in your 8 policy opportunities, which is inequalities. Inequalities are actually huge in, you were discussing only tonight inequalities in developed world, but inequalities are increasing in developing countries, especially in transition countries in Eastern Europe, where the private sector is actually taking part that is very unregulated. My question is, could you comment on corruption regarding efficiency as well as inequalities?
So in 2000, when we first published our first attempt at looking at health system efficiency, which was a little bit different than what I was talking about here, it was really just relating resources to final health outcomes. There was a series of other people who took the same data and analyzed the relationship between efficiency and measures, for example, of corruption and government effectiveness, and it turns out there is a statistically significant relationship. So there's some very macro evidence that suggests that, in fact, governments that work well also, not surprisingly, do public health and medical care well, and those are often governments that don't have a lot of corruption. So I completely agree. It's got to be one of the factors that account for variation in performance.
Right over here.
Andrea Lambrinidis, I'm a Kennedy School grad, and my thanks to you, Dr. Murray, and to Kyriangelopoulos for embarking on this most necessary endeavor. My question is, could you comment on the logistical impossibility of containing the avian bird flu if and when it strikes Africa? What are the ramifications and policy options?
So first, a caveat here. I am not a bird flu expert. I'm very interested in the potential magnitude, like I think everybody in the room and everybody else is, in the magnitude of a potential bird flu epidemic. And the one thing we can do is use historical evidence on what actually happened in 1918 with the best available mortality data and what happened in the pandemic in the 1960s. But there's a lot of things that are different in the world today, and there's a lot of strategies that might be used. But I don't think from the historical evidence that the 1918 pandemic eventually pretty much got everywhere. I've actually went once to Kiribati in the Pacific, and I was asking, do you keep mortality data? And they said, oh yeah, we have mortality data. Former British colony, the Gilbert Islands, and they pulled out these old logbooks. And sure enough, they had data there of a huge increase in mortality in 1922. And the belief was that that was how long it took for the Spanish flu to actually reach a remote island in the Pacific. The message there is that pandemic probably got to absolutely everybody. So it may not be very likely that you will stop the eventual spread to everybody. So the way to mitigate has got to be around both supportive care, antiretrovirals, vaccination probably being the most important. Quarantine strategies may create the window of time for vaccination strategies to be effective. So that's the one part where there's a powerful interaction. But that's all I could say on that one.
Right over here.
Hi, Dr. Murray. My name is Christian Christofferson. I'm a Norwegian medical student and currently doing research down at Children's Hospital. I was just wondering, I understand that there's a lot of things that we don't know about how, for instance, Malawi and Swaziland do use their money. But I was interested in your thoughts on what we do know that they do differently, what we should assess, what are the biggest challenges right now, what we do know that we could assess in this stage, if you can say something about that.
For the pair of Malawi and Swaziland?
Not really, but like basic things that we do know, because I mean, I've understood now that there's a lot of questions and we don't have enough information. What kind of information do we know? Do we know anything in general that you would, if a government official comes to you and asks you, okay, where am I going to start? Because there's a lot of countries out there that has that starting point, to put it that way. What would
No,
you
I
tell them?
think that's in some ways the most fundamental question that we all are asking, which is, even if we're relatively early in the evidence-based health policy arena as compared to the evidence-based medicine arena, where we've all used to practicing evidence-based medicine after 25 years, what do we know currently? I think we know a number of things on the finance side, which is if you're looking at a low or a middle income country, the worst thing you can do for public health and medicine is use out-of-pocket payment to finance your healthcare, to use user fees. It's been a bit of a disaster. The policy prescriptions to introduce those, for example, in rural Africa in the late 1980s. So that seems quite clear macro and micro evidence to support that claim that we should use tax-based or insurance-based financing, both for the avoiding catastrophic spending, but just also for utilization and access. Another area that seems to be very clear is that countries are frequently driven by donor-funded program priorities, even though there are tiny resource flows vis-a-vis the total. At the margin, the money flowing, for example, into sub-Saharan Africa has enormous influence on the policy priorities for ministries. And so one attribute, I think, of systems that you see that do well is the combination of good leadership, and there's a whole big question about how you create that, and how do you end up with a Julio Frank as a minister of health, or other dynamic ministers of health that have come along. And having information available so that governments can pick the priority programs that map their epidemiological profile and opportunities and have some way to defend against whatever set of programs may be externally financed. Articulate ministries of health are able to sort of turn things in the right direction. But I will be the first to confess we have a lot to learn about what are the ingredients of success, and that's the ultimate goal.
This will have to be the last question.
My name is Charlie Atkinson. I was in the School of Education, and I'm an entrepreneur involved in global healthcare learning delivery. And my question is, where do you see the best opportunities in using education and training to work with your 8 policy initiatives?
Well, I had more than 8, I'll have to confess. So I chopped off about a bunch because I could easily go on and have more. In the set that had 10 was the whole issue around human resources and the sort of human resource crisis that we're seeing in a number of developing countries. And there's a real component to that, and then there's one that there's a lot of political posturing about. The real component is that if, as we see, there's a steady scale-up of resources going to the poorest countries, we hope that increase from 2 billion to 4 billion is going to keep going, and there's every indication that it probably will, or at least for the next 3 or 4 years. the international financing facility for immunization alone that Gordon Brown in the UK has been key in developing is another $4 billion for the Global Alliance for Vaccines and Immunizations. So there's signs on the horizon that there'll be big resource increases, Global Fund for AIDS, TB, and Malaria, PEPFAR, et cetera. But the problem is that will countries who are most in need actually have any nurses or doctors or any other appropriate health personnel to deliver expanded programs? And there's lots of indications that in a belt across sub-Saharan Africa, eastern and western and central, not southern, which is a different story, there's just an extraordinary shortage of trained personnel. And on top of that, of course, we know from the media that there's this huge sort of cherry picking out of particularly Anglophone ex-colonies by the British-speaking world of nurses trained in Zimbabwe, Ghana, and South Africa particularly, but also some other countries. And so that combination is only adding fuel to the fire. So if the only way there's a solution, there's just this complete and total mismatch between the people available to deliver interventions and the money that's now possible to flow in. So we need to come up with some innovative solutions, or say that we have to wait 10 or 15 years to scale up nursing schools and medical schools. So that was number 9 or 10 on the longer version of the lecture.
Thank you very much. Well, this was a terrific inaugural Angelopoulos lecture. It's a great thing, so I want to thank Ambassador Angelopoulos Daskalaki. I'd like to thank Dean Bloom, and certainly I particularly want to thank Professor Murray for his terrific remarks. You all have a safe trip home, and think healthy thoughts. Thank you.